Hi, I'm Dr. Hall at Chattanooga Non-Surgical Orthopedics, and we thank you for coming in to see us or watching this video. I'm going to talk about the 3 types of knee pain. There's a lot of different types of knee pain, but I toned it down to 3 categories just to keep it simple. Type 1 is ligament, tendon, muscle sprain, strain. That's typically soft tissue injury of the knee. Type 2 is kneecap pain. That's pain under the kneecap. And type 3 is internal knee pain, and that is derangement of the meniscus and the osteoarthritic knee. So for this video, I'm going to talk about type 3, which is internal knee pain. So if you're watching this, you may have been told already you have bone on bone, or your knee is wearing out and you need a knee replacement, or you've been told you need a meniscectomy. So we want to steer you away from those, because the problem with the meniscectomy is it's ultimately going to lead to knee replacement, because you're actually cutting out the material in the knee. So this is a healthy, normal knee, as we see here, and the meniscus is what keeps the bones from rubbing on each other. So if you go in there and cut out the meniscus, you're going to have wear and tear on the bones and ultimately lead to a knee replacement. And with a knee replacement, you're limited in what you can do activities. So if you're into exercise or getting on the floor with your grandkids, a knee replacement is going to make that challenging. So we have conservative methods to offer you to avoid those 2 surgeries. So with internal knee pain, we have a normal healthy knee, and then we got early degeneration, moderate degeneration, and advanced degeneration. And I'm going to talk about moderate and advanced because that's the 2 most common ones that come in the clinic. So what happens with this, we'll go with this moderate degeneration for the sake of learning, is the meniscus is starting to wear out and the bones are getting closer together, and what happens is the cartilage is starting to wear out. So if you look here, we got a healthy dose of synovial fluid. That's the lubricant that keeps the cartilage from rubbing together. It's like motor oil. It keeps the knee lubricated. And what happens is when that hyaluronic acid wears out, the cartilage starts to erode and you start to get bony changes, osteophytes, and that's when you start to feel a lot of knee pain. You're told you need total knee replacement. But what we do is we use a cold laser to decrease inflammation, and we just run it on the knee, and that decreases inflammation without the side effects of corticosteroid, which actually degrade the knee and break it down even further, ultimately leading to a knee replacement. And then we use the percussor, because you've been told, or we saw on your x-ray here in the clinic, that your knee space is tight, it's less, you've lost joint space. So the percussor is used to break up the fascial adhesions, and that helps to restore range of motion and strengthen the knee. So after the percussion is done, we put you on our knee on track unit, which is going to gently open and close the knee joint. This is critical to avoid a knee replacement. This is done 3 times a week for either 4, 6, or 8 weeks, depending on if you're early, moderate, or advanced in your knee degeneration. And what the knee on track is going to do is reintroduce, open the joint space, and it's going to pump nutrients into the knee to start healing up this eroded cartilage. So when the knee is separated, it's going to pull nutrients into that knee to start regenerating the cartilage. Now the problem is we need fresh nutrients. The synovial fluid's worn out. So typically we'll use hyaluronic acid to replace this worn out synovial fluid. Synovial fluid contains hyaluronic acid and fatty acids. Fatty acids is what gives us the cushion. So typically when the knee is really degenerated, we'll inject fat-derived adipose stem cells or mesenchymal stem cells. Now these are like planting seeds in the knee. These seeds are going to allow the regrowth of cartilage and the regrowth of meniscal tissue. So it regenerates these tissues. And research has shown that these stem cells, when properly administered and using the right kind of stem cells, not shady aftermarket stem cells, but the actual legit kind, live stem cells is what we use, will cushion the knee joint and then secrete these stem cells to regrow the tissue. Now these stem cells need fertilizer. So what we do is we use PRP. PRP is where we take your blood, so you're the pharmacy, we spin it down, and then we capture the platelets, and that's platelet-rich plasma, which is used by all the athletes in the world. And we inject that plasma into the knee right with those stem cells, and what that does is that regenerates that knee. It's like planting seeds in, fertilizing it with the PRP, which contains growth factors, and then using our laser is the sunlight to make it all work. And what it is with that combined with the neon track opening up the knee space, you start to increase cartilage volume. So steroids or cortisone decreases cartilage volume. Stem cells and PRP increase cartilage volume. But we have to use the neon track to open the knee up so that cartilage volume can actually separate the knee, because what happens is all these ligaments are so tight where you've lost cartilage and the knee is collapsed on itself, and these ligaments fold up like an accordion, so the neon track's going to lengthen those back out. And then our last step is clinical exercise. We've got to start doing some exercise to re-strengthen the supporting muscles around the knee. So whether you have a Kellgren 2, which is early, or a Kellgren 4, which is advanced knee arthritis, we use those 5 steps I just went over to rebuild and regenerate your knee joint.